Daya. Daya.
Ya, kenapa nanti?
Daya, cuba. Sekejap Cuba kau cakap kejap Sekejap. Lepas aku cakap 1, 2, 3 kau cakap hello Sekejap. 1, 2, 3.
Hello.
Kau
Hello?
cakap tak hello? Cakap tak?
Hello, cakap.
Cakap tadi.
Dengar tak?
Tak dengar tadi. Tak apa. Aku nak test sebab nak buka dekat phone satu. Takut dia lag dekat komputer.
Tak, dengar tak sekarang?
Sekarang dengar dah.
Ah.
Alright, thank you.
Okay.
Next talk. Nak tanya, suara saya bergema ke?
Okey je.
Okey je. Okay. Thank you.
Suara saya dengar tak?
Dengar,
Dengar sikit.
Semua merdu.
Dengar ke tak?
Dengar
tapi
Ada.
Suara
Dengar.
saya tak ada. Okey je.
Okay.
Alright. Semua orang nampak kan?
Nampak.
Okay.
Assalamu alaikum.
Waalaikumsalam.
Can you hear me now?
Yes.
Okay. Good evening and happy day. Today we are going to discuss our seminar.
Yes.
All candidates already attend.
Yes, Doctor.
Are you 28 participants?
Yes, Doctor.
Okay. So let us start by Al-Kitab. بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين اهدنا الصراط المستقيم. Is it our first presenter is Dr. Noor Nadira?
Yes, doctor.
Okay. Let us start. We'll give you a chance to present. Did you send your presentation to me? Because I got the other.
Yes, I did, but I think my email went to the spam like usual. I'm sorry, I think it's in the spam box.
So please, for the next time, you need to send it as one package for the whole seminar. You are 2 or 3 presenter, you will drop all together. But it is a good chance just if you need to do some correction, you or any other colleague, you can send it after that as one package, okay? To me and to Farah. Okay, thank you. Let us start now.
Alright, doctor. Okay. Okay, Bismillahirrahmanirrahim. So, Okay, Bismillahirrahmanirrahim. I am the first presenter for tonight's presentation. I will start the presentation with growth disorder, which gonna talk about the short and tall stature problem. Okay, my name is Noonan binti Azmi. And first, I'm going to talk about the normal growth that comprises of 4 phases. So for the first phases, we talk about the phase in terms of fetal period. Okay, during the fetal phase, it was the fastest period of the growth that comprised 30% of the eventual height. And the size at birth was solely determined by the size of the mother and also the placenta nutrient supply. Okay, regarding the placenta nutrient supply, it is very important because it modulates the fetal growth factors such as insulin growth factor 2, female placenta lactogen, and insulin. Okay, in order for the fetal to have a good placenta nutrient supply, they need to have optimal supply uh, dependent on the adequate maternal diet. Okay. Contrary to the non-belief that the fetal height is dependent on the father height, actually the fact is that the fetal height is independent of the father height and growth hormone. Okay, in cases of severe IUGR and extreme prematurity, it usually associated with poor postnatal growth that could lead to permanent short stature. And during low birth weight condition, the neonates have a high risk to develop metabolic risk of childhood obesity. Okay, then regarding the fetal phase, we move on to the infantile phase. So during this phase, it largely dependent on the good adequate nutrition and good health and normal thyroid function. This phase is considered a rapid phase of growth. However, it has a decelerating growth rate. Okay, it contribute for 50% of eventual height, and by the end of the infantile period, the patient fully change, the child fully changed from the fetal length, which depends on uterine environment, to genetically determined height. Okay. So during this phase, if there is any inadequate rate of weight gain, we call it as a flattering growth. Okay, next phase would be a childhood phase. it is a slow, steady, and prolonged period of growth. It contributes 40% of the final height, and the main contributor for this phase is the pituitary growth hormone. Wait, I want to. Pituitary growth hormone and at the epiphysis, and it become the main determinant of the child rate of growth, provided the child receive adequate nutrition and good health. Other than the growth hormone, they also depends on the thyroid hormone, vitamin D, and also steroid. Okay, if the child have a profound chronic unhappiness, it can decrease a growth hormone secretion that accounts for psychosocial short stature. Lastly, it is a pubertal growth spurt. Okay, pubertal growth spurt. The main hormone that playing a major factor in this phase is the sex hormone, mainly testosterone and estradiol, because this sex hormone cause the lengthening of the bone at the back and boost the growth hormone secretion. And this will add an additional 15% to the final height. Okay. Other than that, sex hormone also lead to fusion of epiphyseal growth plate and cause cessation of the growth. So if the puberty is early than expected age, the final height will be reduced because the faster closing of the epiphyseal plate. Alright. Okay, this is the just a simplified graph, whatever I've been saying. So just the same from the previous slide, only the diagram. Okay, so for the normal average height velocity at, according to the different phases, during prenatal growth, we expect the length will increase 1.2 to 1.5 cm per year, and during infancy, 23 to 28 centimeter per year, and during childhood, 5 to 6.5 cm per year. And once the child reach puberty, for girl, we expect they to increase in height 8.3 centimeter per year, while boys is higher than that, 9.5 centimeter per year. Okay, we actually can estimate the child, the future height of the child by calculating the mid-parental height. So in boys, the formula would be the height of the father plus the mother height plus 30 divided by 2. While the girls, we only change the number of 13. So we minus 13 instead of plus 13 and divide by 2. So we got the estimation of the future adult height for the child. Alright, so how we want to have a good measurement of the height is that we must maintain the equipment to be regularly calibrated. And if the child is aged more than 2 years old, we can we can measure the height by do a standing height measure. Okay, like inside this picture. So this is the correct technique to take the height during standing. And if the child is less than 2 years, we prefer the measurement of the length by put the child lying horizontally. And ask the parent to assist during that measurement. So in infant, to have an accurate length measurement is very difficult because the legs need to be held straight, and infant doesn't like to be held still. So due to that, the routine measurement of length is often omitted, but in our country, we perform it every time the patient visited. Okay, I don't know what the highlight. Okay, this the figure showing how we want to measure the length of the infant. Okay, if the measurement is further from the mean, more likely the child has a pathological cause of his or her short or tall stature, as you can see inside the on this graph. So if the height was far away from the mean, there is abnormalities needs to be investigated there. So the significant abnormality of the height is when the measurement is less than 0.4. Means that less than 0.4 or more than 99.6 centile outside the mid-parental age. Mid-parental height range. And we consider the measurement to be abnormal also if the measurement of the height is so different from the weight gain of the patient. And we also need to further investigate if during serial measurement, the centile growth crossing the normal line for the growth check after the first year of life. Alright. Okay. So for the first topic will be the short stature. It was defined by height below third percentile. Means that 2 standard deviation for age and gender. Okay, that's the first definition. Second definition is when the height significantly below the genetic potential. Means that it below the mid-parental height calculation that we do. Okay, or the height is abnormally slow growth in velocity. And also when the height is crossing percentile channel on growth chart. Usually the child is more than 18 months of age. So we need to investigate further what is the causes for that to happen. So the causes can be divided into 5. Okay, for the first one is endocrine disorder. Usually for the endocrine disorder, the length or the height will decline first than the weight, or it will decline at the same time as the weight. Okay. So the weight for the height is normal or elevated, low bone age compared to high age. Okay. In terms of nutritional insufficiency, the weight will decline first. Okay. Difference from the endocrine disorder. Okay. So the weight for height is low unless the patient already developed chronic stunting. So the weight for the height is suit each other. Okay. In terms of pathology, congenital pathologic short stature, this can be applied in children who born small and grow gradually, taper off throughout the infancy. So the causes that could contribute to the congenital pathologic short stature would be chromosomal abnormalities such as genetic disorder, for example, Turner syndrome, and perinatal infections such as HIV, child born with extreme prematurity, and had exposure to the teratogen products such as phenytoin or alcohol. Okay, other causes for this short stature would be constitutional growth delay. Okay. This condition has characteristic of weight and the height decrease near the end of the infancy. However, it follow the norm during the middle childhood and accelerated growth towards the end of the adolescent. And once they achieve the adult age, they achieve the normal height. So the problem only will appear during the infancy period. Okay. So okay. And then familial short stature. Okay, familial short stature is when the child and the parents are small. So they follow the parents. The growth run parallel to and just below the normal curve, and the bone age normals because there is no pathological problem with this. Okay. Alright, this is based on the PITS protocol. Just the same with the division just now. Okay. Okay, same lah. Alright, so I'm going to talk about more constitutional growth delay. So it is a variant of normal growth actually. It commonly encountered by pediatrician. The length and the weight measurement usually normal at birth, and the growth is normal for the first 4 to 12 months. However, the height sustained at lower percentile during the childhood. Okay. The pubertal growth spurt is delayed and the growth rate continue to decline. Okay. The problem only occur during infancy or early childhood, as I can conclude based on the constitutional growth delay. But in terms of history, we can found that there is other family members that have history of short stature during childhood or delay puberty that eventually they develop a normal stature. Okay, so investigation that we can do in this type of patient is that we can do IGF. But usually the result low for chronological age. Chronological age is the age of the child at that point of time. Okay, but within the normal range of bone age. Bone age is the age of the bone itself. Alright, it's different. Okay. So growth hormone response is lower in children with constitutional growth delay because they have a delay in terms of puberty. Okay. This is to differentiate within familial short stature and constitutional growth delay. Okay. In terms of familial short stature, major characteristic is that it is a normal characteristic, except that the adult height is short because they follow their parents. However, for the constitutional delay, the problem is during the early infancy where the growth rate is late. Otherwise, they still achieve a normal adult height. Okay, alright. Okay, next one. After that, we go to the growth hormone deficiency. It can classify under congenital or acquired. So for the congenital, the causes may be idiopathic, but the acquired causes could be due to the secondary to birth injury, such as there is any prenatal infection or apa it's okay lah. Okay, and then the presentation for the growth hormone deficiency would be severe growth failure, delayed bone age, and weight or height ratio increase. Regarding the weight or height ratio, I will explain later. Explain further later. Okay, investigation that can be done for growth hormone deficiency. First, we measure the level of growth hormone, measure the level insulin growth factor 1 and insulin-like growth factor binding protein 3. Okay, these two marker actually very sensitive for the growth hormone. Okay, and then we measure the bone age based on the radiograph of the left hand and wrist. Okay, next we moving on to the genetic disorder. First genetic disorder that I'm gonna talk about is Turner syndrome. Okay, Turner syndrome actually they have 45 XO chromosome. Okay, the one of the X chromosome is partly or completely missing. It can be due to the Mossad karyotype. So the incidence would be 1 in 2,000 female infant. We can diagnose prenatally by doing amniosynthesis or chronic villus sampling. We also could send for standard 30 cell karyotype analysis. So the incidence does not increase with high increase in maternal age, and the risk for the second pregnancy to develop Turner syndrome is very low. Okay, so clinical features in Turner syndrome based on the Sunflower textbook, there is a leaf edema of hand and feet in units that could persist until the childhood. So we can also see there is spoon-shaped nails, short stature, which is a cardinal feature for Turner syndrome, neck webbing or thick neck, as you can see inside the image, this image, and wide carrying angle, cubitus valgus of the limbs, widely spaced nipples. You can see the nipples very away from each other. Congenital heart defect, particularly coarctation of the aorta, delayed puberty, ovarian dysgenesis that contribute to the infertility and However, the pregnancy is still possible if they use in vitro fertilization, but it's not permissible in our religion, right? And then they also can have a problem with thyroid, hypothyroidism, renal anomalies, pigmented moles, recurrent otitis media. In terms of intellectual function, most of them have a normal intellectual function. Okay, next we move on to the popular genetic syndrome, which is Down syndrome. It is a trisomy 21. Most of the cases are secondary to non-disjunction, 95% of the case, and it occurs 1 in 650 live births. Antenatally, we can diagnose through ultrasound, see the knuckle fold thickness, and we can also do amniosynthesis during 16 to 18 weeks of their gestation, send for the karyotyping and fish, and also we could do chorionic villus sampling after 18 weeks for the triple assessment. And in newborn, we can send for blood sampling to detect any medical problem that could arise secondary to Down syndrome. Okay, so the typical appearance of Down syndrome is that they have a characteristic faces. You can see they have a round face and flat nasal bridge, absented palpable features, absent or single palmar crease, widely spaced first and second tooth, and many more. Can read later. Okay, moving on to the Noonan syndrome. So Noonan syndrome actually the problem is when there is a mutation in autosomal dominant gene, but the karyotype is still normal. The diagnosis is actually based on the clinical sign. So but we can seek help to confirm this diagnosis by sending for molecular genetic testing. Okay, actually the Noonan syndrome can be said is a male version of Turner syndrome, right? But it can affect female also, right? So the clinical features of the Noonan syndrome, they have a characteristic faces, same as the Down syndrome, but They have different characteristics. So we can see there is a large head compared to face, right? And then there for white space eye, hyperthyroidism, epicanted fold, you can see there, and short broad nose. Alright, what else? Excess knuckle skin. You can see there are swollen edematous at the dorsum of hands and feet. They also have problem in terms of learning difficulty, short Weber neck with trident hairline. What I found is that Noonan syndrome have association with pectus excavatum. Okay, and they also have a congenital heart disease such as pulmonary stenosis and atrial septal defect. Okay, and then rader-Willi syndrome. Okay, rader-Willi syndrome incident is 1 in 25,000 of live birth. It's due to the deletion or unexpressed deletion on paternal chromosome 15. So to diagnose this, we must do genetic testing. The clinical features, same like before, they have a characteristic faces. Characteristic faces, you can see difference from the other syndrome. They have thin upper lip and smooth philtrum. Okay, and then they usually presented with hypotonia and neonatal feeding difficulties, fluttering growth in infancy, obesity in later childhood, hypogonadism, developmental delay, and some learning difficulties. Okay, the last one under the short stature differential diagnosis would be achondroplasia. Achondroplasia is the most common disproportionate growth of short stature, fall under bone dysplasia. So the prevalence is approximately 1 in 20,000 of live birth. It is an autosomal dominant due to the mutation in fibroblast growth factor receptor type 3. So the characteristic for this diagnosis would be rhizomelic shortening, which is the shortening of the limb of the proximal limb. Shorten limb proximally, such as at the humerus and femoral. They also have a brachydactyl, short digits, kyphosis, lordosis, saddle nose deformity, various knee deformities, and cervicomedullary compression. I already stated what is the meaning of those terms that I mentioned. So this is the figures that showing achondroplasia. As you can see, they usually have a posture of marked lordosis and prominent abdomen. Alright. Okay, so we approach, based on the pediatric protocol, the suggestion to approach patient with short stature is that we take history and antenatally, ask regarding the complication of pregnancy, preeclampsia, hypertension, maternal smoking or alcohol that could lead to growth hormone deficiency and any infection. And we need to know the history of the birth, the gestational age when the child actually delivered. Is it premature or birth weight and the length, because low birth weight could lead to the obesity. Okay. Mode of delivery of the child, Apgar score, and is the child develop any neonatal complication. We need to know the developmental milestone, since genetic syndrome usually have problems in terms of milestone, and we need to know the nutrition, the general well-being, the appetite, energy, sleep, and bowel habit, the pattern of growth from the birth, and the maternal and child relationship, such as psychosocial. Such a patient could develop psychosocial short stature if they have any disturbance in terms of psychological problems. Okay, medical history, need to know the underlying illness, such as uncontrolled diabetic mellitus could lead to stunted growth. Need to know the medication that the child take, any exposure to any irradiation. And regarding the family history, need to cover if patient have any history of short stature inside the family. And then age of onset of puberty for the constitutional delay of growth, and any disease inside the family. Okay, in terms of physical examination, the basic measurement would be the height, weight, and head circumference. But we need to have a height velocity chart, because it's very important to evaluate the rate of growth per year. Okay, it is more sensitive than the normal height chart that we use. And it has a specific indicator of abnormal growth. That's why it primarily being used by pediatric endocrinologists. So we need also to measure the arm span and need to know the body proportion by calculating the upper and lower segment ratio. Okay, so lower segment is the length from the symphysis pubis to the floor. Okay, so the normally in units the ratio will be 1.7 and adult will be slightly less than 1.0. That is normal. So when the patient have a higher upper lower segment ratio, there is a characteristic of short limb dwarfism or bone disorder, such as cats. So other than anthropometry, noted the general appearance and behavior, any dysmorphism, and what the child is currently at the pubertal stage, right? Okay, so initial screening that can be done to evaluate the growth failure is that first general test, full blood count, renal profile, liver function test, ESR and urinary analysis. So we need also to send chromosomal analysis in every short girl because Turner syndrome actually very difficult to diagnose clinically. So we need to consider the diagnosis of Turner syndrome in every short girl. Okay, that's why we need to send chromosome analysis. Alright, and then we need to send for endocrine test. We measure the thyroid function test, the growth hormone, and do growth hormone stimulation test if we found the growth hormone has um, deficiency. Okay, and then regarding the imaging studies, this is where we apply the measurement of bone age. Okay, we do epi-radiograph of the left hand and wrist. And then we can also do CT or MRI brain if hypopituitarism is suspected. So under investigation depends on our clinical suspicion. The suggested investigation would be blood gas analysis and radiograph of the spine because of the lordosis and kyphosis just now. Okay, the management generally we treat the underlying causes. If it is due to the hyperthyroid, we treat the low thyroid hormone. If it is due to uncontrolled diabetic meter, we treat the DM. And if patient have suffered from any chronic illnesses. Okay, for the child suspected to be growth hormone deficient, we need to refer to pediatric endocrinologist to initiate for the growth hormone treatment. And then we need to give psychological support for non-treatable causes, especially if the patient actually experience short stature secondary to genetic or familial short stature. So the indication for the growth hormone treatment is for the patient that really have a growth hormone deficiency, Turner syndrome, patient with small gestational age, chronic urinary insufficiency, idiopathic short stature, rader-Willi syndrome, and its cachexia. So for the growth hormone treatment, it could only be initiated by the pediatric endocrinologist. So the dose would be 0.025 to 0.05 milligram per kg per day. Subcutaneously, we give daily at night. So it should start with low dose and titrated according to the clinical response, side effect, and growth factor level of the patient. So during the treatment, we need to monitor 3 monthly and assess the growth parameter compliance and evaluate for the adverse effect. So we expect the patient that have a growth hormone treatment, they may develop side effect of impaired glucose tolerance or carpal tunnel syndrome. Okay, other biochemical evaluation, we send for the thyroid function, HbA1c, lipid profile, and fasting blood glucose. So the growth hormone treatment need to continue until the child reach near the final height. Final height defined as the height velocity of less than 2 cm per year over at least 9 months. Over at least 9 months. Okay, so other than the growth hormone treatment, we need to treat other pituitary hormone deficiency such as hypothyroid, hypogonadism, hypocortisolism, and diabetes insipidus. Okay, done regarding the short stature. Move on to the tall stature. Okay, tall stature we define as the length or height equal or more than 97.7 percentile, which is more than 2 standard deviation compared with the reference population. So usually regarding the tall stature, few children or families seek treatment because it is socially acceptable and maybe advantage to that child itself. So referral for tall boys are rare, but and referral for tall girls were common in the past, but now increase in social acceptance cause they less to come to seek treatment. So there is a 4 question we need to ask if patient presented with tall statures. First, we ask, is the child height abnormal from the population? So normal range would be within -2 and +2 standard deviation. Next question, is the child grow abnormally rapid? So the abnormal rapid, to determine whether the child have abnormal rapid in growth, we need to see the height velocity. Okay, this require a serial measurement. All right, and okay, okay. So the third question is that is the child grow within the range for the family? So how we need to know this? We need to know. We need to do mid parental height calculation just now. All right. Okay, but that technique is actually less accurate as it does not reflect the disease process or environmental contribution to the growth. Okay. The last question is that is there any evidence of accelerated growth? So to know if there any evidence of accelerated growth, we need to measure the bone age. So we take a radiograph of the left hand and wrist, and we use technique of Bailey Pinner to compare the radiograph with the bone age atlas. Okay. The method is valid for the child 6 years old, and tend to be overestimate if we use this technique in child uh, less than 12 years old. Okay. So alright. Okay. Bone age is important as it could help in determining the differential diagnosis for the child rapid growth, especially if it is secondary to endocrine causes. Alright. So the cause of the excessive growth or tall stature, the first one, the most common cause is familial. Means that the parents is tall, so the child tall. And next, obesity, and could be secondary to the hypothyroidism, excess sex steroid, excess adrenal androgen steroid, or due to the true gigantism, due to excess growth hormone secretion. The tall stature could also be found in genetic syndrome, such as Marfan, homocystinuria, Klinefelter syndrome, and Soto syndrome. Okay. So excessive growth at birth means that there is proportionate tall stature since birth, maybe due to the maternal diabetes, primary hyperinsulinism, or back with syndrome. Okay, this based on the Nelson, but just the same. Okay, how we want to approach? Okay, when we measure the height of the child, if it is more than 2 standard deviation, we see the child. If the child have any dysmorphism, we go through this pathway. Okay. So if we see whether the height is disproportionate or not, because if it is a disproportionate growth, the causes may be due to clinical fetal syndrome, Marfan, or homocystinuria, or other causes such as estrogen deficiency or insensitivity. If the growth is not disproportionate, so this is the causes. And then if the height of the deviation more than 2 standard deviation with no dysmorphism, we see whether the acceleration is the recent acceleration or not. If this no, there is 2 options. Okay, there is 2 pathway for no. After we calculate the mid parental height, if the value and the height child have at that moment cross more than 2 standard deviation, okay, it might be due to obesity or estrogen deficiency. If the mid parental the target height doesn't cross means that the height of the child at that moment doesn't cross more than 2 standard deviation from the target height, we consider is at familial tall stature because it's still within the mid parental calculation. All right. And then that one pathway, and the second one, if there any puberty sign. So if there is a puberty sign, we can conclude that the tall stature may be due to precocious puberty or constitutional advance in puberty. Or if there is no sign of puberty sign, it may be due to the pituitary gigantism or hyperthyroidism. Okay, in terms of normal variant or familial or constitutional tall stature, as I said, is the most common cause. Family has a family history with no organic pathological present. Child are taller than peers throughout the childhood and have a normal health. But the parents of the constitutional tall adolescent might feel insecure with their own child. Okay. And then there is no abnormalities in terms of physical examination and laboratory studies. And usually this condition associated with exogenous obesity, and they have a early onset of puberty. The bone age is accelerated, all right? But the adult height eventually normal, okay? And then if the child is have excess growth hormone secretion, it could be uh, the condition could present into overproduction of growth hormone can present into condition whether the epiphyseal has been closed or not. So if the epiphyseal is still open, the child may develop gigantism. If the epiphyseal is closed, the child may develop acromegaly. Okay, the causes may be due to growth hormone secreting pituitary adenoma or hyperplasia of somatotrophs. Okay, for the growth hormone secreting pituitary adenoma, usually the patient will come with complaint of uh, headache, visual field defect, or other pituitary hormone complaint, rather than saying that they have problem with the tall stature. Okay. The characteristic in terms of gigantism, patient have a tall stature, broad hands and feet, prognatism, prominent jaw, broad root of nose, excessive sweating, hypertension, and glucose intolerance. When they develop acromegaly, there will be enlargement of the distal part of the body, circumference of the skull increase, broad nose, enlarged tongue. Okay. And then we can screen this condition by testing the IGF-1 and IGF-BP3 level. As I said before, it's a very sensitive marker for growth hormone excess. And when these markers are elevated, we need to do oral glucose suppression test as it is a gold standard to diagnose excess growth hormone secretion. Alright. Other than that, we can send for MRI to visualize the pituitary mass. So for the genetic syndrome under tall stature, first I will talk about the Klinefelter syndrome, which is XXY syndrome. It is relatively common. In the clinical features, tall stature have learning disability and can require for speech therapy. There are also gynecomastia and decreased upper body lower body segment ratio. I can conclude that Klinefelter syndrome, they have a feminism features. Okay, as you can see, gynecomastia, hip female like. Okay, and affected boys usually have a hypotonia, clinodactyl, and hypothyroidism. Testes are invariably small, and then they have infertility problem and other genital abnormalities. Okay, moving on to the Marfan syndrome. It is an autosomal dominant of connective tissue disorder. So the features is that first they are tall and they have arachnodactyl, thin extremities, increased arm span, and decreased upper body lower body segment ratio, and ocular abnormalities. So that's why patients usually wear spectacles if they will suffering from Marfan syndrome. Okay, and then this is mnemonic, how to remember the clinical features of the Marfan syndrome. This picture show how to do thumb sign. You can see patient with Marfan syndrome, they have a long thumb. Okay, right. Okay, this is the last one. Soto syndrome or cerebral. I can see everyone doing the thumb sign. Okay, cerebral gigantism. So we can see that usually patients with cerebral gigantism, they have a length and weight above the 19th percentile. And patient could also have a microcranium, means that the skull is big. It can be due to the mutation in SD1 or due to gene microdeletion at the chromosome 5. So it is an autosomal dominant and the incidence is 1 in 14,000 live birth. The growth usually rapid. By 1 year of age, the infant taller than 97 percentile in height. So, okay. It continue until the first 4 to 5 years, but eventually they return to the normal rate of the growth. Okay, puberty still at the same time, but the adult height are at the upper normal range. The clinical features for the Soto syndrome, they have a large head, macrocephaly, and dolichocephaly head. Okay. They have a prominent forehead and jaw, hypothyroidism, antimongolic slant, high arched palate, large hand and feet, In terms of the gait, it was clumsy and awkward. They have difficulties for the task requiring coordination, and they have 25% risk to develop seizure in their life and risk of malignancy. And usually at school age children of Soto syndrome, they will develop scoliosis. Okay, so investigation for this diagnosis would be we send for the growth hormone and IGF-1, but it is normal. So it's helpful in differentiate whether the patient has Soto syndrome or excess growth hormone secretion. And management is usually symptomatic management with special attention to development and behavioral problems. Alright, this is the picture that I can find regarding the Soto syndrome. You can see in this baby, prominent forehead, telencanthus and epigastric fold, flat nasal bridge, down slanting of the palpable features and pointed chin. So this is the same child at the age of 4 years old. But from what I can see, it look normal to me, but that is the features of the Soto syndrome. It's more prominent in this cartoon picture. Okay, so investigation, general investigation, baseline, we do karyotype analysis, send for thyroid function test, send for IGF, measure the bone age, and calculate the mid-parental height. Special investigation that we could send, if we suspect the tall stature secondary to precocious puberty, send for the serum LH, FSH, and testosterone level, do glucose separation test for send for visual field examination, MRI to visualize the pituitary, measure the serum cortisol and prolactin. Okay, management, majority of the patient with tall stature require no intervention. So we just need to explain and reassure the parents and the patient. We reassure by explaining regarding the bone age. Okay, and then we consider the impact of the patient features in terms of their quality of life and their family expectation and potential complication that could develop from their condition. But we still can offer treatment to limit the growth in those with adult height more than 3 to 4 standard deviation. Okay. And if they have a significant psychosocial impairment. Alright, so management that we could offer is high dose sex steroid. As I mentioned before, sex steroid accelerate the puberty and promote the epiphyseal fusion. Okay, so we can give estradiol and testosterone, but estradiol has side effect of weight gain, nausea, benign breast disease, excessive vaginal discharge, or in terms of testosterone, patient could develop acne and gynecomastia. Other than that, we could offer surgical treatment of epiphysiodesis, which is we surgically destroy the growth plate around the knee. However, later patient can develop leg length discrepancy. Okay, other type of treatment, if patient have problem with tall stature secondary to pituitary pituitary adenoma, we could give octreotide or pigvisomel. Okay, octreotide is a somatostatin analog that suppress the growth hormone production. The side effect of octreotide is have a side effect at the GI and cause glucose intolerance. Okay, before I end my presentation, I just want us to reflect regarding this ayah of Surah Al-Hujurat. Oh, you who have believed, let not people ridicule another people, perhaps they may be better than them. Nor let women ridicule other women, perhaps they may be better than them. And do not insult one another, do not call each other by offensive nickname. Wretched is the name of the disobedience after one face, and whoever does not repent, then it is those who are the wrongdoers. Why I want us to reflect regarding this ayah, because we grow in society or community that like to body shaming other people. So just because we see a different characteristic or features of other people, we could not point that as a joke. Okay. That's all. Thank you.
Thank you,
Okay.
Nadira. Thank you.
Yeah.
Nice presentation. I would like to give you some comments now before opening question for your colleague. The first and the most important one you need to add is the centile chart. Okay.
Oh, okay.
I used it to tell you before that you may see two babies at the same time. They have like gross impairment. You can find the two child in 5th centile. But if you come and see the logbook and the centile chart, you will find someone was on 5th centile or 10th centile, and now he became 250. What you will tell him? What you will tell the family?
Sorry,
He was in 10th
we need,
centile and increased now became on the 5th, 50.
we need to see the serial measurement of the height.
So we will assure the family and tell them very good, okay? But if you see the baby before on the 9th centile and the cross 2 centile and they become on the 5th, you tell them no, I wonder, I need to investigate. So one reading is not enough by any mean, okay? You must consider the plotting the child in centile chart. I mean more than one readings. And whenever you see infant or children, you must plot him in centile chart. We'll find the logbook in your hand. You must put him, please. So we can diagnose with time. Is it constitutional? Is it some disease? Even like Soto's disease, everyone has its own characteristic, okay? So please, you need to make simple comment about serial measurement of the growth chart. The second one, references. I think most of you are lagging for references. And even if you are writing the references, usually you are just writing what is this? Just writing by not scientific meaning. You must from now and then know how to write a reference, okay? It is very important. The second one, some point like you said, in fetal life, it is independent on the father, but the final height is dependent. So be careful about some expression, okay? Of course, we came to the conclusion at the end that we are adding the maternal and the paternal and make this formula, okay? For gross hormone, hello? Hello?
Yes, Doctor, we can hear you.
You can hear me? Sorry,
Yes.
I don't know. I don't know what has happened. So please, it is very important also during speaking of growth hormone, it is a very good example for us when we are considering the treatment of growth hormone. We must know the investigation which is required, and we must teach the family a lot of details like side effect, because sometimes there is side effect must be considered, okay? Other point, for vitamin D, I'm just telling you some clinical points. You said we need to get the X-ray of the left hand
and wrist.
No, we need to get X-ray of the non-dependent.
Non-dependent.
Yes, non-dependent hand.
Oh,
It means,
non-dependent. Oh, okay. This one.
okay. This is very important, because sometimes if you know the rationale, it will be a good measure for the effect of the vitamin deficiency, vitamin D deficiency. anytime Nadira, you found any baby or a child have crossing a child by more than 2 centile. If he passed more than 2, this we tell this is crossing a centile. You must be very cautious and you must investigate. The last important lesson you can know now that you spend with us about more 1,000 days, have a good theoretical, see a lot of patients, but now we need to start from just knowledge to be practical. Now you need to apply your knowledge. It may be after few months or weeks, you may start your job and you will find a one with short or long stature, and you have a big series. All of these details which you said, it must be apparent in your head, and every patient in his own merit needs some correct diagnosis of you. That's why to become professional. That's why we are trying to give you problem-based seminar. Okay, I hope it is clear for you. Inshallah, hoping the best for all of you. Anyone need to ask a question?
Prof, I have a question.
Yes.
Regarding the non-dominant hand, may I ask what's its relation with the growth? And the second question would be that how frequent do we do the bone age using the plain radiograph?
How frequent? The second question is?
How frequent do we measure the bone age using the anterior posterior radiograph?
Yeah, I'm speaking about for vitamin D. They said the non-dependent hand will have a frank picture than the non-dependent one, the active one. The rationale for that we may need to revise, but it is documented. It is better to use the non-dependent, which is used less. For bone age, it is a very important really. And it depends upon the ossification and the number of bones in the hand. And at that time, you need to go very deep. If you are able to make enlargement of the hand bone, so you are going to compare the bone age and the chronological age. Okay, it is done. Any patient you are going to transfer him to endocrinology, usually they are going to retrieve it, especially on failure to thrive like that, or short stature. Any other question?
If you have no question, we could pass to the second presenter.
Okay, so please, you need to make correction of your presentation, and we can go for the second one. Next presenter, please.
Thank you, Doctor.
Okay. Can you go ahead?
Denise?
Just a second.
Siapa second?
Aklan.
Aklan.
Just a second. Sorry, problem with my computer. So everyone can see my slide.
Yes.
Okay,
Yes.
so Assalamualaikum warahmatullahi wabarakatuh. So my name is Muhammad Akhtan. So I shall continue the presentation for today. So my topics will be a approach towards inborn errors for metabolism. So this is a bit of a recap from our year 1 block 1 lectures in the biochemistry. So this is the outlines of my presentation. So we are going to talk about introductions. Then we're going to go into classifications, approach towards inborn errors or metabolisms, and we're going to see some of the notes on some important inborn errors of metabolisms, and we're going to look into references. So my main references for this topic will be Nelson, this protocol, and also Harper's biochemistry. Okay. So as a part of an introduction, so the definitions of inborn error from metabolisms are basically also known as inherited metabolic disorders. It is groups of heterogeneous condition that is characterized by genetic mutations in a metabolic pathway. So it is the defects will be in terms of the quantity or the quality of the protein being expressed by the gene, and this will cause disruptions of the metabolic pathway. So as you can see the diagram, so we can see that the defect will be between B and C. So when there's a defect in the metabolic pathway, then B will accumulate. C and D will be less in terms of the quantity. And because of the excessive accumulations of substance B, then it will activate alternative pathways to become substance E, if there is any alternative pathways. So most of the inborn errors of metabolisms are autosomal recessive in natures. Hence, there are some history in regards to consanguinity that we need to look in terms of the diagnosis. So common features of all inborn errors of metabolisms, first and foremost, the consanguinity history will be pivotal in terms of to aid our diagnosis, because most are autosomal recessive, hence we requires 2 genotypical mutations in order to express the phenotype. And of course, among those who harbors the mutations, it have a variable expressivity. So this is a term used in genetic disease, where every one of those harboring such mutations, even though the genotype is same, but the phenotype might not be the same. Some will be severe, some will be less severe as compared to one another. And then the third one will be all of them are clinically well after birth. So they are antenatally and also postnatally normal. However, they will experience clinical deteriorations afterwards, usually after introduction of feeding, because of the metabolites needs to be broken down from the food. And also, severe mutations will lead to earlier manifestation as compared to a less severe one. And of course, important for us to learn about this is because some of them are treatable, and we can avoid mortality and also morbidity by diagnosing early and institutes appropriate treatment. So we're going to look into some of the classifications. So if you refer Nelson's, there are some other different scheme that we can use. However, this one based on this protocol is the one that we're going to use because it is more relevant clinically. So in short, it is largely divided into 5 major metabolic disorders. We have group 1, disorders that give rise to acute or chronic intoxications. Group 2, impairments of the fast intolerance. Group 3, affecting neurotransmitters. Group 4, disorders of the biosynthesis and breakdowns of complex molecules. And the last one will be mitochondrial disorders. So group 1 and group 2, they are the one that we need to diagnose early because most of them have appropriate treatment. And also most of them can be diagnosed quite easily as compared to other. And these 2 groups, the first one and also the second group, are relatively more common as compared to the others. The acute and chronic intoxication, and also the one that cause fast intolerance impairment. So this you can lead later on. So going to look into some of the approach. So we're going to start with clinical histories, physical examinations, investigations, and eventually some initial steps of management. So of course, it is to be considered in any acutely ill child. However, the presentations of inborn error for metabolism, it's not specific. The presentation is more or less resembles the sepsis, neonatal sepsis, either it is early onset or the late onset. So we need to consider it as part of our differentials in acutely ill child. Symptoms implicated written textbooks will be poor feedings, vomitings, lethargies, and convulsions. And specifically about this convulsion is that it does not respond towards B10, B6 or calcium treatment. And eventually patients can also develop coma. So in the presence of these symptoms, then we need to consider the possibilities of sepsis and also the possibilities of the child having inborn errors of metabolism. So generally, patient will have poor tone. However, in MSUD, maple syrup urine disease, patient will have hypertonic and also opistonotus posture, the arching back, just like we see in tetanus. And so when do we want to suspect inborn error of metabolism? Those with consanguineous history, consanguineous marriage among cousins, for example. Clinical iterations after feeding, as I mentioned before, antenatally and postnatally, immediately it is baby will be fine. However, once we start the feeding, then the problems will start to occur. So also we need to consider in child with acute encephalopathies, with fevers and vomiting, and those with unexplained metabolic acidosis or hypoglycemia, which is some of the biochemical manifestations of inborn error for metabolism. And also histories of unexplained siblings that is death in neonates. So this might be that those particular siblings are actually having inborn errors of metabolism, but it is undiagnosed. And maternal history of HELLP syndrome. So it is mentioned in literatures that it has an association that mothers with HELLP may have a child with inborn error for metabolism. And also, if the child have unusual smell or like fruity odor smell or maple syrup smell or sometimes sweaty feet smell. Okay, so these are the things that we need to put in our mind when we want to consider inborn error from metabolism. So having said that, we've covered about the clinical examinations and the history. So we're going to look into investigations. So this is the flow chart as being listed in Nelson textbook. So in the presence of one or more of the following symptoms, we need to consider work up towards inborn error for metabolism. So as I mentioned before, the symptoms are as stated above. So we need to consider infection, especially sepsis, traumas, CNS anomalies, and also metabolic disorders. So we need to take the plasma ammonia. So because there are many IEM, many inborn error of metabolism that will have hyperammonemia as part of the clinical manifestation. So take first the plasma ammonia, so we can see it is high or normal. If it is high, then we need to proceed further with anion gap calculation. So anion gap, the formula will be the potassium plus sodium minus the chloride and also the bicarbonate ion. So we get the anion gap. So anion gap, normal anion gaps in the presence of hyperammonemia will suggest a urocycles defect, whereas those with high anion gaps indicates acidosis. So we need to consider organic acidemia. And also those with normal ammonia and also normal anion gaps, we need to consider aminoacidopathy such as maple syrup urine disease or phenylketonuria. So some of the disease under this will be covered later on. So after that, we do some basic metabolic investigation. So we need to order for, this one is taken from PITS protocol. Among those that we need to add it into the workup would be serum ammonia, glucose, lactates, blood gas, and also urines for dipstick. Okay, and then we need to consider special metabolic investigations, acylcarnitine for fatty acid oxidation defect, amino acid, which is measured in the plasma or serum, organic acid in urine, and also orotate, urine for orotate, if we suspect urea cycle defect. So in Canada, UK, and also USA, is actually incorporated in universal neonatal screening. meaning that every unit will be screened for inborn errors of metabolism. However, because of the limited resources in Malaysia, that we only do workup for IEM if it is clinically indicated, if we have the clinical suspicion. Right. So these are some of the screening programs that is done in USA. Actually, this table I take because it's basically it's summarized in beautifully the IEM that we're going to cover. Some of it actually, I not cover all. Okay. Now approach towards IEM. After we done the basic workup, then we're going to do some initial management and resuscitation. Of course, we need to treat hypoglycemias with D10 solution and also metabolic acidosis, which is it's part of the some of the IEM will present with such manifestation. And also we need to restrict the protein intake because of the defect is occurring at the metabolic pathway, hence it cannot be metabolized. So we need to restrict the protein intake. However, the restriction should not be more than 48 hours because the infants will require protein eventually. So eventually we need to restrict some of the constituents of the protein diet. We'll go further later on. And also we need to maintain adequate calorie intake. So this is actually the aim is to prevent catabolism. So we know that when we want to produce energy, we will metabolize carbohydrate first, then we will metabolize fatty acid, then later on metabolize the protein, our protein. So we want to prevent that. So we want to provide adequate calorie to the children in order to prevent such catabolism. So the aim will be 120 kilocalories per kg per day. Intralipid, D10 solution, and also protein-free diet is part of the calorie requirement and supplementation that we're going to give the patient. So how long we want to give? Until the patient's ammonia and also the acidosis is normalized. And then this is actually, all of it is the general management before we know the diagnosis. The thing about IEM is that sometimes the clinical deterioration is so rapid that fatality can occur before even our investigation result come out. So we need to take appropriate action fast. Okay, and then we need to anticipate complication. And then general supportive care if the patient has seizure, which is common, especially in patients with hyperammonemia. So we need to give anticonvulsants. Those with respiratory insufficiency, we need to ventilate them. And those with cerebral edema, which is also common in those with hyperammonemia, we need to give mannitol furosemide in order to reduce the cerebral edema. Okay, now after we know the specific diagnosis, so we're going to tally our management accordingly. So these are some of the treatments. The first table, this one, is actually found in treatments of hyperammonemia. So we have what we call as the anti-hyperammonemia drug cocktail. So basically, indications will be when the plasma ammonia level is more than 200 micromoles per liters, and when the patients have encephalopathy as part of the clinical manifestation. So what we're going to give, sodium benzoate, plus sodium phenylbutyrate, and also plus L-arginine. So the dose are just quite simple, 250 mg per kg. All of it to be mixed with D10 solution until reaches the 50 cc volume. Then we need to infuse over 90 minutes duration. Maintenance dose, same formulation, but we need to infuse over periods of 24 hours. Okay, and then we also need to do dialysis. Dialysis would be to remove the toxic metabolite, especially the ammonia. So these are the stated, that is the indication to institute the hemodialysis in the patient. So for other protein metabolism disorders, we need to tally accordingly to specific diet based on specific pathology. This one I will cover later on. And also those with organic aciduria, we need to consider to give carnitine. Okay. So we're going to cover some of the important inborn errors of metabolism. So we go into the general classification just now. Group A includes the aminoacidopathy. So aminoacidopathy is basically the inborn errors of metabolism involving the metabolic pathways of amino acid. All right. So first we're going to cover about phenylketonuria. So I'm sure all of us have heard this before in year 1 block 1 lectures by Prof. Zamzila. So basically the defect is actually involving the phenylalanine hydroxylase enzyme. So as you can see in the metabolic diagram, so phenylalanines will then be metabolized to become tyrosine by the enzymes of phenylalanine hydroxylase. So imagine we have a cut there, so phenylalanines will accumulate within blood, tyrosine will be reduced. So these phenylalanines, the excessive one will then be converted to become phenylpyruvate, as I mentioned before, activation of the alternative pathway, and this will be converted to become phenylketone, which is the phenylacetates and also phenylactate. These are the one, the lactate and phenylactate and phenylacetone is the one that give the urine its fruity odor smell. All right. So just a summary of what I mentioned before. So excessive phenylalanines will be converted to become phenylketones. So presence of phenylketones in the urine is actually indicating severe disease. Okay, so when we smell the fruity odor smell in the urine, that means the phenyl BKU is actually severe. All right. So the problem with phenylketonuria is that this excessive phenylalanine, it will go to the blood-brain barrier. So blood-brain barriers is selectively permeable. So amino acid requires specific transporter proteins in order to be transported into the brain. So the problem is that these phenylalanines will saturate all of the amino acid transporters. So amino acids such as tryptophan and also tyrosines, which are required for neurotransmitter synthesis, they will compete with one another, and these tryptophans and tyrosines will lose in terms of the competition, and then our brain, or sorry, the child brains will have less neurotransmitter synthesis. Hence why we can see mental retardation in this particular group of children. Now, some of the clinical features and intellectual disabilities gradually develops over time, as I mentioned before, because of the lack of the neurotransmitter, because of the oversaturation of the amino acid transporters, fruity odor urines, as mentioned before, because of the presence of phenylketones, due to the excessive phenylalanines in the plasma, vomiting, and also psychiatric manifestations, ADHD and autism spectrum disorders later on when the patients grow into childhood, and also developmental delay as the patients grows. Screening, tandem mass spectrometry. So actually, I've tried asked doctor before that this tandem mass spectrometry is actually a screening tool used in USA, Canada, and UK, but it is not used in Malaysia. So for diagnosis, we just use serum phenylalanine management. Specific will be phenylalanine slow diet. So we cannot restrict fully the phenylalanine because it is essential amino acid. So as we learned before, that essential amino acid is required to be taken by diet. So without it, we cannot survive. So we need to restrict it to a low amount. Second disease, I'll cover briefly about maple syrup urine disease. So you can see the metabolic pathways. It basically involves the branch keto acid dehydrogenase enzyme, in which these enzymes will be deficient. So valine, isoleucine, and leucine, these three are essential amino acids, but the catabolism will be impaired because of this disease. All right. So we have 5 clinical phenotypes. Classical MSUD, which is the most severe one, characterized by the absolute effect of the enzyme. We have intermediate MSUD, intermittent MSUD. Intermittent MSUD is actually patient is normal, but during the periods of catabolism, for example, patients have fever, patients have surgery, patients have trauma. So in this catabolic state, patients will have MSUD. So it's an acute on chronic presentation. And then thiamine responsive MSUD are the one that responds towards thiamine. And the last one, the rarest clinical phenotypes will be the E3 subunit deficiency. Okay, so the clinical features, poor feeding, lethargic, convulsion, coma, stimulus to others, IEM, cerebral edemas, and also hypertonics and opisthonatus posture, as I mentioned before. In contrast with others IEM, where others usually present with pure tone, hypotonia, but this one will be hypertonic. And then death can occur after a few weeks and months if left untreated. So in a less severe form, for example, as I mentioned before, that there are several clinical phenotypes. So the less severe form, the intermediate form, the mental retardations is eventually because of its longer duration. So it is less fatal as compared to the classical MSUD. So in this particular group, same goes with phenylalanine. This leucine, isoleucine, and valine, they will compete with the amino for the site at the amino acid transporters in the blood-brain barriers. So competitions will render lack of tyrosine and tryptophan intake, and our neurotransmitters will be decreased, so patients can have mental retardation. Okay, diagnosis, amino acids analysis. So we're going to see, because of we just imagine we have a cut in the metabolic pathway. So anything before will be elevated, anything distal to the metabolic pathway will be decreased. So we can expect elevated valine, isoleucines, and leucine. And also we can we can measure, we can do the enzymes assay to measure for the enzyme activity. And also if we are to do neuroimaging, then we can see during the acute phase, we can see cerebral edema. However, in the chronic phase, for example, those with the intermediate form, so we can see the cerebral atrophy. Treatments for the acute one, we need to promote hydration because we want to promote diuresis. However, because renal clearance of the leucines, isoleucine, and valines are actually not so good, so we need to consider dialysis if it is inadequate response. And also for those with cerebral edemas, IV mannitol, hypertonic solutions. And of course, we want to prevent a state of catabolism. So we need to ensure adequate calorie intake under 20 kilocalories per kg per day. Treatments for chronics, we need to restrict these, leucine, isoleucines, or valine diet. But we cannot, because they are essential amino acids, so we cannot cut them off totally, but we need to restrict them altogether. Next one, urea cycle defect. So this is the urea cycle as we all know and love. Some enzymes that are important are highlighted in red. So we have the carbamol phosphate synthetase, and then we have the ornithine transcarbamylase, arginine succinic acid synthetase, arginine succinic acid lyase, and arginase deficiency. So you can go back and try to look at the urea cycle. Actually, it's a very important cycle clinically. So this basically in urea cycle defects, they were present with hyperammonemia. All right. So patients we have, as I mentioned before, common symptoms of IEM, convulsions, comas, lethargy, school feeding, vomiting, and because of the hyperammonemia, patients can develop cerebral edema. Infants and also older children can develop ataxia, mental confusions, agitations, combativeness, irritabilities, and coma. All right. Diagnosis and management. So I think we've covered before in our general approach towards investigating IEM. So major cerebral ammonia will be elevated and 9-GAT will be normal. So we also need to do amino acid plasma measurements. So we expect anything proximal, it will be elevated. Anything distal to the defects would be decreased. But bear in mind that urocycle defect is actually a general term. So those, as I mentioned before, that those 5 enzymes that is involved in the entire cycle can have the pathology. So different site of enzyme defect will lead to different measurements of the plasma amino acid. So just go to the urocycles and see each one of the pathway. All right, enzyme acid and gene study to measure for the enzymatic defect and mutation. Treatments, as I mentioned before, we need to treat the hyperammonemia, and long-term will be protein restriction. And we can tally the treatments of acute hyperammonemia treatments, the cocktail. So we can give it as a chronic management where we, but there's some alteration in terms of the dosage, but we need to give it as a, actually these benzoates, the phenyl butyrates, and also the arginines, actually it promotes the excretions of ammonia. Basically, it forms a complex with ammonia, so it will promote the renal clearance of ammonia, because ammonia, the renal clearance is not as much. So by giving these medications, we can promote the renal clearance of this ammonia, hence reducing the toxic levels within our blood. Organic acidemia, I think this one I'm not going to cover in detail because it's not as common. So basically the ammonia will be elevated and 9-GAT will be large, being organic acidemia and aciduria. So we can expect metabolic acidosis. All right. So these are my references. So with that, I think that's all for my presentation. So I put the floor to comments from Prof, and also if there's a question. Thank you.
Thank you, Dr. Zaki. Nice presentation. Can you hear me?
Yes, Prof.
Okay. Again, they used by Arabic to said ميدان الكلام غير ميدان العمل، ميدان العمل غير ميدان العمل المتقن. I mean now we have a lot of knowledge, but for the next time we are going to start to do, okay? And after that, we need to make it more professional. That's why simply please, you will have a lot of patients, usually if infants, as you told, most of this is inborn errors of metabolism will be discovered in the early neonatal time when the baby started to feed, okay, with a history in the family like that, consanguinity or other. But most of us are concentrating on sepsis, okay? That's why you must ask yourself, it is not sepsis. What can be else? It can be cardiac. It is not cardiac. What can be else? It can be CNS problem. It is not there, so must consider inborn errors of metabolism, okay? Especially if you have some clues. I just remember the time in UK, during the round, I found one mother, really, this is the first time to see UK usually is very friendly and but we did round and the mother is sitting and giving us her back. She didn't keen for anything and the physician did his round for this patient. This is inborn errors of metabolism, maple syrup urine disease. She was referred from that hospital for this regimen of treatment. Baby is okay, just to continue the management, and he left. I really became very wonder and I go and visited the mother. Mom, can I know the story of your child? She told me that my child came 2 or 3 times to the this, and he said bad words to these doctors, has hypoglycemia, and they are not able to even think about that until I contact another consultant, and he said you must go for inborn errors of metabolism. When I did, I found my child has. So now I am just coming for them to give me the treatment only. I am not keen about them. You see how much it's traumatic for anyone to miss something like that, okay? It gives us lesson in our life, please. With time, you will find the infection is the top, yes, but it is not the sole one. And to have an approach is very important, like just a simple blood sugar, blood gas, serum ammonia. If you have suspicion, you can make the basis. It will guide you, okay? I didn't want to make it complicated, but please go through the history. Even tandem screen, which you speak about, is very important in many countries. My country in Saudi Arabia, we are doing it for about 18 disease. I think Malaysia is on the way because it is not the only to do the tandem screen for this all. It will be done by the same which you are doing G6PD and the hypothyroidism. You will add in the same tests. But the issue is you need a complete unit for diagnosis, and then you need, because inborn errors of metabolism, most of them are treated by diets and some L-carnitine, L-arginine, as you speak about. So it is very important. And I think Malaysia, I expected it will be soon, inshallah, in that field, especially if some of you become funded about that branch. And this is the importance. If every one of you thinking about subspecialty. We are not in need of a lot of general physician. We need a lot of subspecialty. And even in Islam, if you lose some subspecialty, you have ism. You are not good at the time until you cover that one. So we speak now about inborn errors of metabolism. Your colleague about speaking about growth and the development, and then we are going for another specialty, and you are doing about 20 seminar. All of this is guide you. Please, if you are able to go for subspecialty after become a professional in the general, this is a requirement of your country and your ummah. Okay, thank you. Anyone need to ask about that? Remember, please, that fasting for many cases of inborn errors is very dangerous. And if they got hypoglycemia, so take care if any stress, including the fasting. You need to ask any questions?
Prof, should I have a question? Do we need to do the neuroimaging in IEM? Because textbook mentioned that we can see the finding, but I thought that is not really required for the diagnosis, Prof.
Yeah. Sometimes you need according to the urgency, because some cases will come like in comatose state like that, so you need to for urgently. But if the tandem screen is came and it is available, you must take care that it is available, but it is not doing as a mass. In a suspicious, you will refer the patient to them. They have a lot of things to do, but in some points of our work, we may need to get the MRI for the brain, especially if the patient experienced hypoglycemia for a long time. It can affect and cause some side effect on the cortex like that. Okay. Any other question? Okay. So the last, not the least now.
Assalamualaikum.
Alaikum salam wa
I'll be
rahmatullah.
presenting.
Okay.
Okay. Okay, I'll start presenting. Can you guys hear me?
Yes.
Okay. Okay, so today I'll be presenting about sepsis and also septic shock. Okay, so we start the definition. So what is sepsis? So from Pitt's protocol, it mentioned that sepsis is a life-threatening organ dysfunction that is caused by dysregulated host response towards an infection. So you need to remember the keyword dysregulated host response, because I will be mentioning it many times after this. Okay, so that is from Pitt's protocol. So from up to date, sepsis is actually a spectrum of clinical syndrome that complicates a severe infection, a pre-existing infection, and is characterized by systemic inflammatory response syndrome, immune dysregulation, microcirculatory derangement, and organ dysfunction. So sepsis, it can happen from just SIRS with infection and increase in severity until it causes an organ dysfunction. Okay. So this is the spectrum of the sepsis. So in order for us to say that that patient is having a sepsis, it has to be fulfilling a few criteria of SIRS with evidence of infection. Okay, because SIRS, systemic inflammatory response syndrome, it can be because of infection or non-infective cause. Okay, so sepsis is SIRS with evidence of infection only. So from sepsis, it can progress into to increase in severity into severe sepsis. So what is severe sepsis? It is sepsis with an organ damage. There is involvement of organ damage lah. And then it can progress further and increase severity into septic shock. So this is when the severe sepsis, and on top of that there is persistent hypertension. Even though we keeps on giving fluid resuscitation, but then the patient still having hypertension. So that is when we say that the patient has septic shock. So this septic shock can also progress later, causing multi-organ dysfunction syndrome and leads to death. Okay. So as I mentioned before, in order to say that the patient has sepsis, the patient needs to have a few criteria of SIRS and also infection. So the infection, it can be either suspected or proven infection, can be clinically or from lab investigation. So for example, for the clinical syndrome, we have high suspicion of this patient having infection. For example, the patient comes with fever and also rashes, petechiae and purpura, and at the same time also having hemodynamic instability. So we are very suspicious that this patient is having meningococcal infection. Or other condition where the patient had fever, cough, and also hypoxemia. And on top of that, there is also evidence of leukocytosis and also pulmonary infiltrate. So we will be very suspicious that the patient having lower respiratory tract infection. Or we can prove that there is infection by investigation, for example, culture or PCR or tissue stain. Okay, so that is for infection. It must be either suspected infection or proven infection. And second is systemic inflammatory response syndrome. Like I mentioned before, it can be due to infection or not because of infection. So as you can see from this picture, so the one on the right side is SIRS that is caused by non-infective causes. For example, like pancreatitis, probably due to gallstone or alcohol, and trauma, burns, and it also can be, SIRS can be caused by infection. So when there is infection and also SIRS, we can call it sepsis. And bacteria is the most common cause of sepsis. Okay, so like I mentioned before, the patient needs to fulfill 3 criteria of the SIRS. So there are 4 criteria in total, and at least 2 criteria must be fulfilled, and one of the criteria must be abnormal temperature or abnormal leukocyte count. Okay, so the first one is temperature. It can be hyperthermia 38.5 or hypothermia 36 degrees Celsius. The temperature can be taken from the rectal, oral, or central catheter. Okay, so for the tachycardia, it said that the heart rate is mean heart rate more than 2 standard deviation above the normal age, above the normal for the age. So in absence of external stimuli, chronic drugs, or painful stimuli, meaning the heart rate increase, the increase in heart rate not because of external stimuli or other causes. So, or it can be due to, or the tachycardia is unexplained persistent elevation for half an hour up to 4 hours. Or in children that is less than 1 year old, they can have, instead of tachycardia, they can have persistent bradycardia, about the mean heart rate less than 10th percentile for their age. In absence of, there's no vagal stimuli, they are not on beta blocker drugs or congenital heart disease that can also cause bradycardia. Okay, so the third one is respiratory rate above 2 standard deviation above the normal for their age, or they need for mechanical ventilation, but then not related to neuromuscular disease or general anesthesia. And the fourth one is the leukocyte count can be elevated or depressed according to their age, and not secondary to chemotherapy. Or from the whole blood picture, there is 10% of immature neutrophils. So from up to date, it has there is mention about the heart rate, tachycardia or bradycardia based on the age group. from newborn up to adolescents. So okay, you guys can look at it later. Okay. So just now I've given you the definition of infection and also SIRS. So sepsis, like I mentioned before, there is 2 out of 4 criteria and also evidence of infection. And this is the spectrum that I mentioned just now. So for severe sepsis, when there is sepsis plus organ involvement. So for example, cardiovascular organ dysfunction. So these are the criteria. There is, despite giving IV fluid about 40 ml per kg for 1 hour, there is still hypotension. Or the patient needs 4 vasoactive drugs to maintain the blood pressure. Or 2 of the following when there is metabolic acidosis, or from the arterial lactate there is 2 times above the normal limit, or there is oliguria or prolonged capillary free time, and when there is a gap in the temperature more than 3 degrees Celsius. So these are the criteria for the cardiovascular. And number 2 is if the patient has sepsis and also ARDS. And this what defines ARDS: when the participation oxygen less than 300 mmHg, or there is bilateral infiltrates on the chest radiograph with no evidence of left heart failure, or when there is sepsis plus two or more organ involvement, for example, the renal, hematology, or hepatic, and so on. So these are the criteria for severe sepsis. Okay. So septic shock is when there is severe sepsis involving the cardiovascular system, and there is persistent hypoperfusion or hypotension despite IV fluid resuscitation, or if the patient require any vasoactive agents. So that is when we said that the patient has septic shock. So why I show you this table is in shock there is 5 types of shock, and one of them is the septic shock. And septic shock, it does not only on its own, it also involves other types of shock. So under septic shock, there can be multiple forms of shock. For example, hypovolemic shock, distributive shock, and also cardiogenic shock. So hypovolemic shock is because there is reduced in effective circulating plasma because of either hemorrhage, external causes like hemorrhage or diarrhea, or internal loss, for example, like capillary leakage. So it the fluid diffuse into the interstitium. Okay, second is distributive, means there is abnormalities of the vasomotor tone, means the vessels is unable to vasoconstrict. So there will be vasodilatation. So it also leads to distributive shock. And lastly is cardiogenic shock. When the mediators that form during the sepsis, it can cause myocardial depression, so lead to cardiogenic shock. Okay. So for the pathophysiology, basically, for example, when there is an infection, in Nelson you mentioned that our host immune response was unable to properly recognize the pathogen, or they are unable to completely clear the infection. So there will be still circulating pathogens there. So this pathogen can form a super antigens or release endotoxin. So these two things can activate the inflammatory cascade and cause the SIRS that we mentioned before. So SIRS with infection, evidence of infection, we cause sepsis. So in sepsis, there will be inflammatory cytokines release, also activation of the coagulation system, and also the complement system. And also it causes injury to the vessels, right? So it will cause activated endothelium and produce more mediators. Okay, so all in all, in sepsis, there will be hypovolemia because of the capillary leakage, cardiac and vascular failure because of all the cytokines will cause myocardial depression, capillary leakage, and also ARDS due to the mediators as well. And the IVC is because of the activation of the coagulation system. It will cause thrombosis in the small vessels. And it also can cause decrease in steroid synthesis. So this is for the sepsis. So if the sepsis is progressing and ongoing, that affects the heart and becoming reduced in cardiac output, it later become a septic shock. And as it progress more, it become MODS and also death. Okay, so there's a few risk factors that can develop the patient into septic shock. First is the extreme of age. When the patient is less than 1 month, so prone to get septic shock. Second is serious injury, for example, penetrating wounds or severe or extensive burns. So it is hard to heal, so it is more more easily to get infected. Okay. Third is chronic debilitating medical condition. For example, in cerebral palsy patient with quadriplegia, they tend to have aspiration pneumonia, so they will have a recurrent pneumonia. So this recurrent infection can also predispose to infection, to sepsis. Okay, host immune suppression, yes, those patients with immune suppression can have higher risk of getting septic shock. For example, those with malignancy or chronic disease, for example, like chronic disease, for example, like patient with thalassemia, for patient with thalassemia, they can have asthenia, right? So unable to remove the encapsulated pathogen, so also increased risk of getting sepsis. Last, surgical incision, indwelling catheters, and lastly is urinary tract abnormalities with recurrent UTI. Okay, so the pathogens can be divided into 4. First is bacterial. These are the common ones, Staphylococcus and also Streptococcus. So the Staphylococcus aureus and also Streptococcus pyogenes can cause toxic shock syndrome, which later can cause sepsis as well. Other than that, less common, but Neisseria meningitis, even though it's less common, but then it is very significant. It can cause life-threatening condition. So always needs to bear in mind, especially if the patient comes with fever and also rash. So meningococcal septicemia should be the first in mind. Second is virus, can be due to respiratory viruses. For example, influenza, very common in Malaysia, and also RSV. Other than that is dengue virus, also common in Malaysia. For immunocompromised patient, Epstein-Barr virus and also cytomegalovirus. For neonates and infant, HSV. Okay. And recently, in the up-to-date, also mentioned that those patients with COVID-19 can also lead to sepsis. So they said that Kawasaki disease-like or toxic shock syndrome-like features in children with evidence of COVID-19 infection or exposure to COVID-19. They also can progress into sepsis. Okay. Other than that is fungal infection, but then this is more common in those with immunocompromised patient. Either they are having malignancy or indwelling catheters or prolonged neutropenia, or they have recently used antibiotics. Okay. The pathogens could be parasite, for example malaria, so we need to suspect based on their epidemiology, based on where they live, or if they have a history of jungle trekking and so on. Okay, clinical features. Okay, so clinical features are divided into few. First is divided into finding the source of infection. Tak nampak slide. Okay, jap. Sorry. Okay. Can you see now? Okay. So for the clinical features, first we need to find the source of infection. So this I take from the up-to-date. But I think the generally we need to look for source of infection in every system available, but not only for the system. We also need to look for if there is any indwelling instruments like catheters or or if there's any
خلصت
wound
الطول الأحمر.
or burn. Okay.
انت هنا بقى ده دورين جراشات 1 2 3 4 5 6
Can you guys see my
ماسكة
slide?
3 نواصي.
هو بتاع أساس كام دور؟
Yes, we can see.
كام دور أساس؟
دي 12
Because I can proceed to the next.
12 غير 2 جراشات.
11 دول جراشات.
ها؟
12 ده بس
لا
جراش.
في 2 جراشات تحت.
طب عندهم اهو.
واحد
Can you see the
واحد
next
دكاكين
slide?
تحت الأرض.
واحد محلات.
تحت الأرض.
جراشات تحت الأرض.
احنا فين بقى هنا؟
Can you guys see the next slide?
Nampak
أخلص
Anis?
الطلبة بس.
No.
Tak.
أخلص الطلبة بس.
Anis macam dah keluar hilang slide. Kena share screen balik semula.
Okay. Sorry, I need to use a better connection.
لسه ربع ساعة كده كتير.
Okay. Can you see my slide now?
Yes, now it's clear. Yes.
Okay. Okay, so that's basically it for the finding the source of infection. Second is the clinical features for sepsis. This I take from the illustrated textbook Sunflower. So basically for the history, fever, poor feeding or irritability, and also we need to find the history of focal infection like I mentioned before, or if the patient had predisposing condition, for example sickle cell disease or immunodeficiency and others. For the examination, basically according to the criteria of CIS that I've mentioned just now, whether the patient having fever, hyperthermia or hypothermia, tachycardia or tachypnea. Okay. And also, this is the picture of a rash. It is a macular rash with irregular border. There are a few petechiae and there are also purpura with a necrotic center. So upon the blanching test, it is non-blanchable. So this is a meningococcal rash. Okay. So the clinical features for septic shock, it can be divided into two. There is warm shock and also cold shock. So basically warm shock is the early stage of the shock where the body is still able to compensate the shock. So in warm shock, it is basically due to the mediators that is produced during the sepsis. These mediators have few effects. It can cause increase in heart rate, it can cause vasodilatation. And as you can see, the criteria of the warm shock, the peripheries are warm and flush. This is because during the early stage and because of the mediators, they can cause vasodilatation, right? So the patient will appear warm and flush. So as the body is still compensating, the capillary filter time is still less than 2 seconds. And also, like I mentioned just now, the mediators it cause increase in heart rate and increase in. So the body also at the same time compensating and increasing cardiac output. So there will be increase in systolic blood pressure. So there will be a huge gap between the systolic and also the diastolic. So there will be a bounding pulse. Tachycardia. So the blood pressure is still able to be maintained during the warm shock, and also the pulse pressure is widened. Okay. So during the cold shock, it is when it is the late stage when the shock has progressed and the body is unable to compensate anymore. So there will be reduced in cardiac output and there will be vasoconstriction. So the peripheries will appear cold, clammy, and cyanotic. So the capillary filter time will be more than a second. The pulse is very weak and the heart rate initially will be tachycardia, then become bradycardia. The blood pressure is hypertension and the pulse pressure will be narrowed. Okay. So we important to know warm or cold shock because it also affect the management. Okay, so this divided the early and late signs, which is the warm and the cold shock, into the ABCD assessment. So in patient with septic shock, usually the airway there is no significant signs. For breathing, they can have increase in respiratory rate, which is tachypnea, because of the metabolic acidosis. So they be increase in breathing to remove the carbon dioxide, or because of the ARDS due to the sepsis. Okay, for circulation, tachycardia is the earliest sign, and then followed by the warm shock features, and later the cold shock. Okay, for the disability, once the shock is progressed, first the patient will become restlessness, and later it will be deteriorate. Later patient will have decrease in mental status. And for the exposure, we need to properly expose the patient, just in case if there is any important rash like the meningococcal rash or even signs of the IBC. Okay. So the conclusion from here is that hypotension is basically the late signs. So we cannot equate shock with hypotension. So we need to find the earliest sign, which is the tachycardia, and the other signs first. Okay, then the investigation. So for the bedside test, you can do capillary blood glucose, because in sepsis it can happen both hypoglycemia or hyperglycemia. Other than that, we can also do EBG or VBG to assess the metabolic acidosis. Okay. Next, for the blood investigation, we also need to do a complete blood count to look for any signs of a key infection, for example, neutrophilia or neutrophilia. And the ominous sign is when there is reduced in white cell count, that is the signs, that is the late sign already. Okay. Other than that, serum lactate, high in lactate amount. This also indicates the hypoperfusion. So when there is hypoperfusion, there will be increase in serum lactate. Okay. Other than that, serum electrolytes, they will be reduced in sodium, reduced in potassium, and also reduced in phosphate. So for the blood urea nitrogen and creatinine, we need to look for features of dehydration. When there is increase in urea and also nitrogen, means there is dehydration. And also when there is increase in serum creatinine, it also can denote that the patient is having a renal dysfunction. Okay, so blood calcium also need to be taken, because hypocalcemia can worsen the shock. Because when there is hypocalcemia, it can cause inability of the vessels to vasoconstrict, and also for the heart to contract. LFT also needs to be done to look for features of liver dysfunction when there is increase in total bilirubin, and also increase in ELT as well. Okay. So next is, because in sepsis there will be a coagulation system activated. So we also need to do coagulation profile. So there will be increase in PT and PTT, and also INR. This indicates that there might be the IVC. Okay, other than that, fibrinogen oxidodimer also indicates the IVC. And for the blood culture is for us to find the pathogen, so that we can give the right antibiotics. And urinalysis, we want to look for any pyuria, any nitrites, or increase in white cell count that can denote urinary tract infection. And lastly is urine culture. So for radio imaging, we can do chest X-ray for pneumonia or any features of pulmonary edema or heart failure. Other than that, depends. CT brain can be done if it is suggestive of the patient. If the patient have sepsis, so there will be abnormal coagulation profile, and also reduce in mental status. So we need to do CT brain. We can also do CT abdomen if we suspect any intra-abdominal abscess, and specific test depends on our suspicion, depends on the differential diagnosis. So for the management from PITS protocol, divided into 4. So first is the initial management. So once we recognize that the patient has septic shock, so we need to resuscitate based on the ABCD. And then need to establish intravenous catheter, or if unable to do so, we opt for intraosseous access. But this is only only temporary measure lah. Later we still need to find for intravenous or central access. So the intravenous access is important because we want to take blood for investigation, and also we want to resuscitate the patient. Okay. And for the fluid resuscitation, in the PICS protocol, you mentioned that we need to give 20 ml per kg crystalloid of 0.9% saline and maximum up to 40 ml per kg. Okay, and other than that, other than saline, we can give Hartmann solution. And at the same time, we need to give empirical antibiotic within the first hour of diagnosis. So for at the right side, you can see the empirical antibiotics for less than 30 months old patient. You can give cefotaxime or penicillin, CPEN. If more than 3 months, we can give ceftriaxone and also or cefotaxime. Okay, so if the fluid resuscitation is still unsuccessful, we need to opt for anotropes or vasopressor, which is adrenaline for cold shock. And if the patient is in warm shock early stage, we can give noradrenaline. Okay, so once the patient fail the fluid resuscitation or the patient needs inotrope or vasopressors, we need to treat them in the ICU. Okay. So that is the initial management. This is for the inotropes. Preferably, we use the central line because it actually irritative if we give it peripherally, but during the initial management, it is safe to give it peripherally because we want to do things fast. Okay. And at the same time, we need to do invasive BP monitoring for continuous BP monitoring. Okay. So for peripheral administration, it needs to be diluted. And these are the alternatives for the adrenaline and also the noradrenaline. Okay. Next is the respiratory support. It depends on the conscious level of the patient. If the patient is conscious, we can just give non-invasive ventilation like high flow nasal cannula or the CPAP or BiPAP. If the patient is having reduced in GCS, we consider for intubation. And in the PICS protocol, ketamine, the PICS protocol mentioned about ketamine instead of other sedative agent because ketamine is rapid in onset. We need to be cautious about sedation in patient with shock because it can deteriorate the hemodynamic instability. Okay. And then, okay, so we need use T and FiO2 to keep the SpO2 92 to 94 and the partial pressure oxygen up to 80 mm/Curie. We need to monitor the peak and expiratory pressure. If it is high, it can impede the venous system and even cause hypotension, further hypotension. So for the management, we can take, if the patient having lactate level of more than 4, later we need to take regular lactate level just as a guide to resuscitate because this denotes the hypoperfusion in the patient. From lactate level, we can know the level of hypoperfusion. Okay. And also we need to maintain the blood glucose 4 to 8 millimole per liter. And lastly, we also need to do echo to determine the fluid status and also the cardiac function. Okay, so what are our goals in resuscitating the patient with septic shock? So if the patient, for the cardiovascular, if the patient have tachycardia, so we need to treat until it normalizes. If there is poor perfusion, then we need to treat until the pulse is equal, the central and the peripheral pulse is equal, and the extremities become warm again. And the hypertension, it becomes normal blood pressure lah. And also for the neural status, the normal mental status, respiratory, we want to improve the breathing and the respiratory rate and renal system. We target the urine to become normal, so more than 1 ml per kg per hour. Lastly is the supportive therapy. If patient we suspect there is adrenal adrenal insufficiency, meaning the patient is in a refractory shock. After we give fluid and after we give vasopressors, still the patient is in shock, then we need to give steroid, IV hydrocortisone. And if we suspect patient is having a toxic shock syndrome, we can give IVIG. In high risk group patient, probably prolonged bed rest with no contraindication, we can give venous thromboembolism prophylaxis. If the patient is anemia or HB is less than 8, we can transfuse with blood. Or if the patient is having AKI that need dialysis, we can opt for the continuous renal replacement therapy, for example, like CAPD or worse than hemodialysis. Stress ulcer prophylaxis, if the patient is high risk of GI bleeding, because in sepsis there is coagulopathy. So if patient is high risk, we need to give prophylaxis, for example, proton pump inhibitor. Other than that, enteral nutrition, if the patient is able to tolerate orally, then we give enteral. And lastly, if family conference, we need to inform the family members about the patient condition and so on. So that is all. These are my references. Thank you. Is there any question?
Thank you, Dr. Anis. Now, who knows what is the abbreviation of SSSS? Hmm. 4S. Staphylococcal.
Scalded skin syndrome.
Yes. The same for sepsis. It is SSSS. And if you are not able to define which is, because the patient may be sick and he can propagate it to have SIRS, or he propagated to end organ failure, systemic failure, or he can go for uncompensated shock or compensated shock. All these are S. But the issue, if you are not able to define which is you are in, it will affect the future of one human being. I mean, the mortality is high, and even if he escaped mortality, he can get organ failure. Remember that, please, because it is a responsibility in front of everyone, in front of the patient and the family, in front of the God, in front of yourself. That's why we must be very meticulous. As I repeat again, while applied medicine, we have a lot of knowledge, we try to handle it. The patient came to me sick, it is very important to define he is propagating into shock or not. And as your colleague defined, the uncompensated shock, usually we are commenting about the blood pressure. If still maintaining the blood pressure, you can survive the organ. Otherwise, if he came shock, he can survive, but he can end by a chronic kidney injury. If a small baby, he will get severe hypoxia, which can cause hypoxic ischemic encephalopathy. So it is very dangerous, okay? Because all organs can be affected if the blood pressure started to be affected, because it is the one which gives the fuel and for all organs. So take care, please. It is not simple to be lazy while the future of other is in danger. That's why, inshallah, you will know that there is BALS or ABILS. BALS is Pediatric Advanced Life Support, and ABILS by the English stuff. As you know, America and UK trying everyone to, so they call it ABILS, which is Acute Pediatric Life Support. Okay, just changing the letter is very important. Okay, and it is not important for this point. No, your future practice needs to concentrate about a high index of suspicious. I must suspect the dangerous thing not to be missed. Number two, early diagnosis and the early intervention. Okay, this is the top priority, please, because your colleague, the first one, she said it is life support, life threatening, and I said, and the organ threatening condition, which is shock. Of course, we are speaking now about one piece of shock, which is the septic shock. We have 5 types of shock also, which can affect like cardiogenic, like others. So it is very important, please. All this knowledge and more, you need to formulate it. When you saw patient, you are able to say this patient going for this direction, I must follow him. Don't tell him, no, you are in the other direction, you must come with me. No. Usually you are following the patient, please. Thank you for that nice presentation. It's your own time if you need to ask or comment, please.
Can I ask one question?
Of course, you can. Yes, Anis.
From this supportive therapy, you mentioned that in patient with, if we suspect there is adrenal insufficiency, then we need to give steroid. But then may I know what is the reason or how does steroid helps?
Yeah, as you know, this is one point. It may be also like suprarenal failure during the time. There is stress, and sometimes it.
Please try again.
One of the drugs to increase the blood pressure. If you start like inotropes, one inotrope, second inotropes, and there is no response, sometimes adding steroid, it will help in increase of the blood pressure. So it is one of the recommended intervention to give steroid during severe life-threatening septic shock besides the antibiotics.
Okay, Prof, thank you.
Welcome. Any other questions? The last advice for you, please. All of you presented a lot of slides from our Malaysian protocol. And I just need to tell you, take care. If you have protocol, it's very important to follow it. Sorry, I used it to say to have a protocol like to have a father. It may be your father is not the best father in the world, but he is a best for you. It is the same. If you have Malaysian protocol, go through it and try to follow it, especially in your starting. When you become a specialist, you can be the one who discuss the protocol and try to change. But at the time, you will realize that the one who is putting the protocol for certain area was correct. Because it is not only you are discussing the scientific meaning, you are discussing all the situation, the impact of this decision on the family, on the economy, in the many areas. What about the prognosis? So sometimes the medicine, as I told you before, is called in, they call the doctor in our area Hakim. Hakim means wisdom man. How are you able to process all this knowledge also by the correct way? Don't try to say I am here by said, oh, I read in UK they are doing, or in America they are doing. If the American came here, they will do like you are doing, because every situation have its manner. Just to speak about the inborn errors of metabolism during crisis, you see what happens in UK for taking many decisions according to COVID. Just one disease, it can change completely what happened in USA. So it is to dealing with a situation is different from try to say, I know. Good to know, and good to present your point to the one who can raise your message to the one who built the protocol. But please go through your protocol and know that guiding with this protocol, you are 99% correct. It may be you are thinking for the one and forgot the 99. No, please. If you are trying to make your own collection to do protocol for everything, you will miss more than 50-60%. Okay? So concentrate on your protocol, and CBG is very important while you are starting for everything. You just go through, because they are making unlimited effort to try to update every time and then. So please consider all this, okay? Don't underestimate. It is, for my point of view, it is a very good job, and may Allah accept that, okay? Thank you, and see you inshallah. And you can send me if you are going to do any correction for the on my email. The other thing for the growth and the development, nutrition. Okay. Okay. It may be I may ask year 3 if they can get some help from you for some points. Okay. I may give him the name of any one of you. Thank you for your nice presentation. And inshallah, hear the best about you. It is a matter of 2 months, inshallah, and see you on frontier, inshallah. Assalamu alaikum wa rahmatullah.
Inshallah, thank you.
Waalaikumsalam.
Salam, Doctor.
Thank you,
Salam.
Doctor.
You are welcome.
Thank you,
You are
Doctor.
welcome. Wishing
Thank
you
you,
the best,
Doctor.
inshallah, for all of you.